Welcome to the Deep Dive, where we unlock the hidden wonders of the everyday. Today, we're going on an incredible journey inside your body, exploring a system so vital, so intricate, yet so often taken for granted, your respiratory system. Prepare for some truly mind-bending aha moments as we zoom right into the microscopic architecture that literally keeps you alive one breath at a time.
That's right. Our mission today is, well, to take you on a detailed exploration of the respiratory system. We want to emphasize how its microscopic structures perfectly enable vital functions, and also, how they're affected by disease. You won't need a microscope because we're going to try and paint a vivid picture of these complex, crucial components that are actively working for you right now.
Okay, let's unpack the big picture first. We often think of breathing as simple, right? Just in and out. But the respiratory system is far more than just inhaling and exhaling. It's actually a sophisticated paired lung system connected by a complex series of air passages.
Precisely. And this remarkable system performs three principal functions. First, air conduction, which is just getting air in and out. Second, air filtration, actively cleaning that air as it travels.
Yeah.
And third, gas exchange, which is the truly critical part, happening deep within the lungs and the alveoli.
Wow.
But it's not just about survival. It also gives us speech production, thanks to the larynx, and our sense of smell from the specialized lining in the nasal cavities. And on a lesser scale, it even plays a role in our body's endocrine functions and how we respond to tiny invaders in the air we breathe. Immune responses, basically.
So where does this incredibly complex system even come from? How does it develop from almost nothing in an embryo?
What's fascinating here is its origin. Believe it or not, your lungs and your lower airways actually start as a tiny pouch growing out from your primitive gut tube during development.
Some in the gut, really?
Yes, a surprising connection to our digestive system. Now, the upper parts, like your nasal cavities and throat, they develop alongside your mouth. So this means the entire inner lining of your respiratory system, its epithelium, has this common origin from your early gut. Endodermal origin, specifically.
Okay, so we've seen how this incredible system forms. But once it's built, how is it organized? Is it just one big tube, more like a complex highway system for air, with different lanes for different purposes?
It's definitely a highway system. Conceptually, it's divided into two main parts, a conducting portion and a respiratory portion.
Okay.
The conducting portion is like the intricate network of roads and tunnels that simply get the air from the outside world down to where the real action happens. This includes your nasal cavities, pharynx, larynx, and trachea, then branching extensively into increasingly smaller tubes inside your lungs called bronchi and then bronchioles.
Branching how many times?
We're talking about 23 generations of branching, getting smaller and smaller and smaller. That's kind of the end of the air highway. Then you have the respiratory portion. This is where the vital gas exchange magic actually occurs. This includes the smallest bronchioles, called respiratory bronchioles, and in tiny structures called alveolar ducts, alveolar sacs, and finally the alveoli themselves.
Okay, here's where it gets really, really interesting at the microscopic level. Let's start right at the entrance, the nasal cavities.
Absolutely. Your nasal cavities are paired chambers separated by a septum. Think of them as the grand entrance hall of your respiratory system. And they have three key regions. First, just inside your nostrils, you have the nasal vestibule. This is lined by tough, skin-like tissue, stratified squamous epithelium technically. And it contains coarse hairs, we call them vibrissae, along with sebaceous glands. Their simple but crucial job to trap large particles before they go any deeper, like dust bunnies.
A first line of defense.
Exactly. Next is the respiratory region, which is the largest part of your nasal cavity. It's lined by a special kind of tissue called respiratory mucosa. If you could peer inside, you'd see three clever, shelf-like, bony projections on the lateral walls. We call them conchae, or turbinates.
Conchae. What's the point of these? Are they just there for decoration, or do they have a job?
Oh, they have a definite job, not decoration at all. They play a dual and critical role. Firstly, they vastly increase the surface area available for conditioning the air you breathe, warming and moistening it.
Oh, okay.
Secondly, and very cleverly, they act like speed bumps and turns in an air highway. They cause turbulence in the airflow.
Turbulence? Why would you want turbulence?
Well, this turbulence is crucial for something called turbulent precipitation. It literally throws particles out of the fast-moving airstream so they smash into and stick to the mucus lining the walls. It's a brilliant way to filter the air.
That is clever, like using physics to clean the air.
Precisely. And the lining of this respiratory mucosa is a microscopic wonder itself. It's a pseudostratified columnar ciliated epithelium. Bit of a mouthful.
Mm.
But basically, it's packed with specialized cells. There are 5 main types. You've got ciliated cells, the most abundant, with maybe 250 tiny sweeping hairs called cilia that constantly move mucus.
The movers and shakers.
Exactly. Then goblet cells, which make and secrete that sticky mucus. You also have brush cells, which seem to be sensory receptors, maybe chemosensory, and small granule cells, sometimes called Kochitsky cells. These are endocrine cells, part of a wider system. And finally, basal cells, the stem cells that tirelessly replace all these other working cells as they wear out.
Wow, quite a team.
It really is.
Hmm.
This whole system warms inhaled air using a rich network of blood vessels flowing just under the surface. It moistens it with secretions, and it filters it, trapping particles of mucus, which the cilia then sweep towards your throat to be swallowed. Think about it. You process nearly 1 liter of mucus a day this way, and it removes almost 95% of particles larger than 15 micrometers. Pretty efficient.
And you can imagine with such an intricate cleaning process, what happens when it breaks down or faces a challenge like an infection or an allergen? What conditions do we start to see then?
Yeah, that's where we encounter conditions like rhinitis, which is simply inflammation of this nasal lining. If it's viral, like the common cold, your tissues swell up, get watery, edematous, and fill with inflammatory cells, neutrophils, eosinophils, mast cells.
Sounds familiar.
Doesn't it? And then there's allergic rhinitis, or hay fever. That's where allergens like pollen trigger certain cells, mast cells mainly, to release chemicals like histamine. Histamine causes blood vessels to leak and glands to secrete more fluid, leading to that familiar runny nose and nasal congestion. It's basically your body's overreaction to something harmless. Microscopically, you'd see lots of eosinophils in allergic rhinitis.
Okay. And what about a big expulsion, like a sneeze? It feels like the whole system is involved in that. How does that work?
It absolutely is involved. Think of it like a perfectly coordinated biological explosion. It's a reflex. It's triggered when tiny sensory receptors in your nasal lining detect an irritant. Impulses shoot to your brainstem, the medulla. Your body takes a rapid, deep breath, almost loading up the cannon. Then, your vocal cords and epiglottis snap shut, trapping the air and building immense pressure.
Right.
Then forceful contraction of your diaphragm and other muscles, followed by a sudden opening of everything. Air and droplets are expelled rapidly, mostly through the nose, at speeds that can approach 180 kilometers per hour.
Whoa, that's fast.
It's an amazing defense mechanism to clear out irritants quickly. And don't forget the immune cells always present in the tissue layers here. T cells, B cells, macrophages, mast cells, providing local immunity right at the entrance. Now, separate from that filtering and conditioning, let's explore your sense of smell. This comes from the olfactory region. It's located at the very top, the apex of your nasal cavities. It's lined by a specialized olfactory mucosa, which in a living person actually has a slightly yellowish-brown tint because of pigment. What's fascinating here is that this area doesn't have those mucus-producing goblet cells we just discussed in the respiratory region. Different job, different cells.
So what cells does it have?
Its lining contains unique cells. Most important are the olfactory receptor cells. These are incredible bipolar neurons. They actually span the whole thickness of the epithelium. At their tip, facing the airway, they have a little knob, the olfactory vesicle, bearing 10 to 23 long non-motile cilia. These cilia contain the G protein-coupled receptors involved in detecting smells.
So the receptors are on these cilia.
Yes. And the other end of the neuron, the axon, groups together with others to form bundles of the olfactory nerve, cranial nerve 1. These pass through tiny holes in the bone, the scribiform plate, to reach the olfactory bulb in your brain. What's truly remarkable and quite unique for neurons is that these olfactory receptor cells are readily replaced throughout life. They only live for about a month. So you're constantly getting new smell detectors.
That's amazing, unlike most brain cells.
Exactly. Then you have supporting cells, or sustentacular cells. They're the most numerous, providing mechanical and metabolic support. They also make odorant binding proteins, or OBPs.
What do those do?
They seem to help ferry the odorant molecules through the mucus to the receptors. There are also basal cells again, stem cells for both the receptor and supporting cells, and a few brush cells, maybe for general sensation.
So how does the smell actually get detected, the transduction process?
It's quite elegant. Odorants, these volatile chemicals, first dissolve in the watery mucus layer covering the olfactory epithelium. Then they might bind to those OBPs, which help concentrate and deliver them to the olfactory receptors, the ORs, on the cilia. These ORs are G protein-coupled receptors. When activated, they kick off a signaling cascade inside the cell, usually involving CANMP, which leads to the neuron firing an action potential, sending a signal to your brain.
And we can smell so many different things.
We can. Humans have over 350 different functional types of these olfactory receptors,
Whoa.
but we can detect thousands, probably tens of thousands, of distinct odors. This happens through population coding. Most odors activate a unique combination of different receptors, and your brain interprets that specific pattern as a particular smell, like a chord played on a piano using multiple keys. Very. And you can also spot specialized olfactory glands or Bowman's glands in the connective tissue layer beneath the epithelium. These are serous glands, meaning they secrete a watery fluid. This fluid isn't just for dissolving smells. It continuously flows across the surface, washing away old odorants and cleansing the receptors, preparing them for new scents. These glands, plus the thick bundles of olfactory nerves, are key identifying features in histology.
Got it. And what about the sinuses?
Ah, yes, the paranasal sinuses. These are basically air-filled extensions of the respiratory region into the bones of your skull. Frontal, maxillary, ethmoid, sphenoid sinuses, they're lined by the same respiratory epithelium. Their function isn't perfectly clear, but they likely contribute to voice resonance, maybe lighten the skull a bit. And interestingly, they seem to be a main site for the production of nitric oxide, or NO, in the airways. NO has antimicrobial properties and might also help regulate ciliary beat and even facilitate gas exchange deeper in the lungs.
But they can also get infected, right? Sinusitis?
Exactly. Because they're connected to the nasal cavity, but drainage can be poor, they're prone to inflammation and infection, leading to that uncomfortable pressure and pain we know as sinusitis.
Okay, so moving further down the airway now, past the nasal cavity, we encounter the pharynx.
Right, the pharynx. Essentially, it's a connector tube. It links your nasal and oral cavities above to both your larynx, airway, and esophagus, food, way below. So it's a dual passageway for both air and food. It also acts as a resonating chamber for speech. It's divided into the nasopharynx, behind the nose, and the ortopharynx, behind the mouth. And don't forget, this is also where the auditory or eustachian tubes connect your throat to your middle ear, important for equalizing pressure. And you find important immune tissue here, too, like the pharyngeal tonsil or adenoids.
And then the larynx, our voice box, this is where sound is actually made, right? So how do those seemingly simple folds create the incredibly complex sounds of human speech? Is it just air vibrating them, or is there more going on?
It truly is amazing. The larynx is the crucial passageway for air between your pharynx and the trachea, and indeed it's the organ for sound production, or phonation. It's a complex tubular structure formed by various irregularly shaped cartilages, mostly hyaline, but some elastic, all precisely connected by joints, membranes, and ligaments, and controlled by intricate laryngeal muscles. Inside, there are two key pairs of mucosal folds stretching across the airway. The upper pair are the vestibular folds, sometimes called false vocal cords. They're generally immobile and protective. The lower pair are the mobile vocal folds, the true vocal cords. The space between them is the rima glottis. These folds contain a supporting ligament and the vocalist muscle, which allows us to change their tension.
So how does that tension create sound?
Phonation happens when expelled air from the lungs is forced through the partially closed glottis, causing the vocal folds to vibrate. Think of it like air vibrating the lips of a balloon as it deflates. The pitch of your voice is altered primarily by modulating the tension on these vocal folds using the vocalist and other muscles. Relaxed vocal cords vibrate slower, producing a deeper pitch. Stretched and tense cords vibrate faster, creating a higher pitch. We also change the width of the opening.
And the actual words?
The sounds produced by the vibrating folds are then further modified, shaped, really by resonance in your upper respiratory tract, pharynx, nasal cavity, sinuses, and your oral cavity, tongue, lips, palate. That's how we produce the distinct sounds of individual speech. So yes, it starts with vibration, but is heavily shaped afterwards. This also explains why factors like allergies, inflammation, or even just being tired can drastically change your voice by altering the shape and tension of these structures.
Makes sense. And the lining here, is it the same respiratory type?
Mostly, but with an important exception. The luminal surface of the vocal cords themselves, and also most of the epiglottis, which covers the larynx during swallowing, are covered with a tough, protective lining, stratified squamous epithelium. This makes sense because these areas experience significant friction and abrasion from rapidly moving air during speech and coughing. The rest of the larynx, however, is lined with the typical ciliated, pseudostratified columnar epithelium of the respiratory tract, complete with goblet cells, designed for cleaning and moving mucus upwards.
And if this delicate structure gets inflamed?
That's laryngitis. Inflammation, usually from viral infections or sometimes chronic exposure to irritants like tobacco smoke or excessive voice use, causes the vocal folds to swell. This changes their vibration, leading to hoarseness or loss of voice. It can also cause coughing, difficulty swallowing, and sometimes even difficulty breathing if the swelling is severe.
Okay, let's trace the air's journey further now into the trachea, the windpipe. What keeps this vital tube open all the time? It seems like it could collapse easily.
Good question. The trachea is your main windpipe. It's a flexible but sturdy air tube, about 2.5 centimeters, maybe an inch, in diameter, and 10 to 12 centimeters long. It extends down from the larynx into your midchest, where it splits or bifurcates into the two main bronchi, one for each lung. Its lumen, the open passageway, is kept permanently open by a series of 16 to 20 C-shaped rings of hyaline cartilage. They act like flexible support beams.
C-shaped, why not full ring?
The C shape is important. The open part of the C faces backwards towards your esophagus, which runs right behind the trachea. This posterior gap is bridged by a band of smooth muscle, the trachealis muscle, and fibroelastic tissue. This allows the esophagus to expand a bit when you swallow a large mouthful of food without being constricted by rigid cartilage. It also allows the trachea diameter to be adjusted slightly by muscle contraction.
Clever design. What about the layers of the wall?
The tracheal wall has 4 distinct layers, from inside out. The mucosa, which includes that ciliated, pseudostratified epithelium, and elastic fiber-rich connective tissue layer called the lamina propria. Then the submucosa, which is denser connective tissue containing glands. Then the cartilaginous layer with those C-shaped cartilages. And finally, the adventitia, the outer connective tissue layer that binds the trachea to adjacent structures in your neck and chest.
Tell us more about the cells lining this important tube. Are they the same as in the nose?
Very similar, yes. The tracheal epithelium is basically the same type as the respiratory epithelium we discussed in the nasal cavity and larynx. You have the principal cell types again, the ciliated cells, most numerous, each with about 250 cilia, forming that crucial mucociliary escalator for removing inhaled particles. Their coordinated sweeping motion moves mucus upwards towards the pharynx. You can often see their basal bodies forming a dark line just under the cilia in microscope images.
Right, the escalator.
Then you have the mucus cells, or goblet cells, interspersed among the ciliated cells. They produce mucinogen granules, which hydrate to form mucus. They often appear clear in standard stains because the mucus gets washed out during preparation. Their numbers can increase significantly during chronic irritation, like from smoking.
Makes sense. More gunk needs more mucus.
Pretty much. You also find brush cells again, columnar cells with short microvilli, likely chemoreceptor or sensory cells, and the small granule cells, or Kolchitsky cells, which are neuroendocrine cells, part of the diffuse neuroendocrine system, DNES. They're hard to spot without special stains, but might play roles in regulating airway or vascular function through local hormone release, maybe involved in reflexes. And of course, the basal cells, the essential stem cell population located near the basal lamina, ready to divide and differentiate to replace the other cell types.
You mentioned the lamina propria and submucosa too. What's going on there?
Beneath the epithelium and its basement membrane, you have the lamina propria, which is loose connective tissue rich in elastic fibers, giving the trachea its flexibility. It also contains numerous immune cells, lymphocytes, many infiltrating the epithelium itself, plasma cells making antibodies, mast cells, eosinophils, fibroblasts. There's also lymphatic tissue, both diffuse and sometimes organized into nodules, forming what's called bronchus-associated lymphatic tissue, or BALT. This is part of your immune surveillance system. The submucosa, beneath the lamina propria, contains larger blood vessels and nerves, and importantly, numerous submucosal glands. These are mixed serous and mucus glands that secrete glycoproteins onto the surface, supplementing the mucus produced by the goblet cells.
Okay, and you mentioned something about the basement membrane being thick.
Yes, that's quite characteristic of the trachea. The basement membrane lying directly underneath the tracheal epithelium is unusually thick, maybe 25 to 40 micrometers. It's composed of densely packed collagen fibers just beneath the epithelial basal lamina. And this has clinical relevance. It can thicken considerably, sometimes dramatically, in smokers or individuals with chronic respiratory conditions like asthma, likely due to chronic inflammation and repair processes.
So chronic irritation, like from smoking, can cause some pretty significant and even dangerous changes here in the trachea and bronchi too, right? Not just thickening the basement membrane.
Absolutely. This leads us to a really key clinical correlation: squamous metaplasia.
Metaplasia, a change in cell type.
Exactly. Squamous metaplasia is a change where the normal ciliated pseudostratified columnar epithelium transforms into a tougher, more resilient stratified squamous epithelium, like the kind you find in your skin or esophagus. It's often seen in the airways of people with chronic bronchitis, bronchiectasis, and especially in habitual smokers. It's essentially an adaptive response by the tissue to chronic stress or injury.
So it adapts to be tougher. Sounds good.
Well, it's tougher, yes, more resistant to the physical and chemical stress, but it's functionally a poor trade-off. You lose the cilia and the mucus-producing cells in that area. This means the vital mucociliary escalator is impaired or lost entirely in those regions. Particles, pathogens, and mucus aren't cleared effectively, building up and increasing the risk of infection and further inflammation.
Ah, so it's a problematic adaptation.
Very problematic. And crucially, if the irritant like cigarette smoke persists over long periods, this metaplastic squamous epithelium has a significantly increased risk of undergoing further changes, leading to dysplasia and eventually malignant transformation. This is a common pathway for the development of squamous cell carcinoma, one of the major types of lung cancer strongly associated with smoking. So metaplasia is often a warning sign.
Wow. Okay. So the trachea branches into the bronchi, which then branch into even smaller bronchioles. What defines these different segments, and how do they change microscopically as the air passages get smaller and smaller?
Right. The trachea divides at a point called the carina into two main or primary bronchi, one entering each lung at the hilum. These then undergo that extensive branching we mentioned, about 23 generations in total. Initially, the large bronchi outside the lungs, extrapulmonary, have a structure very similar to the trachea, including the C-shaped cartilage rings. But as they enter the lungs, intrapulmonary bronchi, and start branching, the structure changes. The C-shaped cartilage rings are replaced by irregular cartilage plates that are distributed circumferentially around the airway wall. This makes the bronchi appear more circular in cross-section compared to the C-shaped trachea.
So cartilage plates instead of rings. What else changes?
A new important feature emerges and becomes more prominent. A complete circumferential layer of smooth muscle located between the mucosa and the cartilage plates. This muscle layer wasn't as distinct or complete in the trachea, but in the bronchi it forms a continuous helical band. Contraction or relaxation of this muscle allows the airways to constrict or dilate, regulating airflow resistance within the lungs.
Okay, smooth muscle becomes key.
Yes. So the bronchial wall typically has 5 layers. The mucosa, with pseudostratified epithelium, though the cell height decreases as the bronchi gets smaller. The muscularis, the continuous smooth muscle layer. The submucosa, loose connective tissue, glands are present here too, especially in larger bronchi. The cartilage layer, those discontinuous plates. And the outer adventitia, connective tissue continuous with the surrounding lung tissue.
And these bronchi supply specific lung regions.
They do. The branching is very organized. Each tertiary or segmental bronchus supplies a specific anatomically distinct region of the lung called a bronchopulmonary segment. Each segment has its own air supply, blood supply via the pulmonary artery branch, and is separated from neighbors by connective tissue septa. This segmental anatomy is important for surgeons, as it allows them to potentially resect a diseased segment without affecting adjacent healthy ones.
Makes sense. Now, what about the bronchioles? How are they different?
The transition from bronchi to bronchioles marks a major change. Bronchioles are generally defined as airways with a diameter of 1 millimeter or less. But the key histological distinction is the complete absence of cartilage plates and glands in their walls.
No cartilage, no glands. Got it. What about the lining?
The epithelium changes significantly too. Larger bronchioles start with a ciliated pseudostratified columnar lining, similar to small bronchi. But as they get smaller, this transitions first to simple ciliated columnar, and then finally to simple cuboidal epithelium in the smallest conducting airways, the terminal bronchioles. Importantly, the goblet cells, mucus producers, also progressively diminish in number and are typically completely absent in the terminal bronchioles.
No mucus cells there. Interesting.
Yes, mucus production stops here, but another cell type becomes prominent.
And this is where we start hearing about those club cells, right? What exactly are they and what do they do? They sound important.
Precisely. Club cells, formerly known as Clara cells, become increasingly numerous as the ciliated cells decrease in the bronchioles, and they are the predominant cell type in the terminal bronchioles. They are non-ciliated cells, characterized by a distinct dome-shaped apical surface that bulges into the lumen. You can see this bulge nicely in scanning electron micrographs. Microscopically, they have features of protein-secreting cells, well-developed endoplasmic reticulum, and Golgi apparatus. Their crucial function is secreting components of surfactant, specifically a surface-active lipoprotein.
Surfactant again. I thought that was in the alveoli.
It is primarily associated with alveoli, but club cells produce a component that acts here in the small airways. Think of this bronchiolar surfactant as a natural non-stick coating. It prevents the luminal surfaces from sticking together and collapsing, especially during expiration when the airway diameter naturally decreases, keeps the small airways patent. They also produce other things like club cell secretory protein, CC16, which is used as a biomarker for lung injury, and they have roles in detoxification and possibly local immune defense. They can also act as progenitor cells for bronchiolar epithelium.
Very versatile cells.
Indeed. Now, the terminal bronchioles mark the end of the purely conducting portion. They lead into the respiratory bronchioles. These are quite unique because they are the first part of the bronchial tree that actually allows gas exchange to occur across their walls. They represent a transitional zone. They have narrow diameters, initially lined by a cuboidal epithelium containing both ciliated cells and club cells. Distally, club cells predominate. The key feature is that their walls are interrupted by scattered, thin-walled outpocketings. These are the first alveoli.
So they conduct air and do gas exchange.
Exactly. They participate in both functions. This marks the beginning of the respiratory zone proper.
And this whole area, the bronchioles, is where asthma really has its impact, right? Leading us to another major clinical correlation.
Yes, it does. This microscopic understanding of bronchiolar structure, especially the smooth muscle and the inflammatory potential, is critical to understanding asthma. Asthma is defined as a chronic inflammatory disease of the airways. It's characterized by recurrent episodes of airflow obstruction, difficulty breathing, wheezing, coughing. This obstruction is due to a combination of factors happening primarily in the bronchi and bronchioles.
What factor?
Firstly, inflammation of the airway walls. Microscopically, you would see the bronchiolar walls infiltrated by inflammatory cells, particularly eosinophils, but also lymphocytes and mast cells. Secondly, constriction of that smooth muscle layer, we talked about this, is called bronchospasm, and it dramatically narrows the airway lumen. Thirdly, the airway lining itself changes. The epithelium can become thick. Goblet cell numbers often increase, leading to excessive mucus production, mucus plugging, and that basement membrane becomes noticeably thickened due to deposition of collagen and other matrix proteins.
And the middle.
Yes, the smooth muscle layer itself often becomes hyperplastic and hypertrophic, meaning there are more muscle cells and they are larger. This exaggerated muscle layer is hyperresponsive and contributes significantly to the severe airway narrowing seen during an asthma attack. All these factors work together to obstruct airflow.
A perfect storm in the small airways.
Exactly. It highlights how changes at the cellular and tissue level directly cause the symptoms experienced by patients.
Okay, now for the grand finale of our air journey, the alveoli. This is where the magic of gas exchange truly happens, right? The endpoint.
Absolutely. The alveoli are the tiny terminal air sacs of the lungs. They are the actual primary sites where oxygen from the air you inhale enters your bloodstream and carbon dioxide from your blood is removed to be exhaled. The business end of the system.
How many are there? And how big is the surface?
The numbers are staggering. There are estimated to be somewhere between 150 to 250 million alveoli in each adult lung, maybe 300 to 500 million total. All these tiny sacs together provide an enormous combined internal surface area for gas exchange. The estimates vary, but it's commonly cited as being around 70 to 80 square meters.
75 square meters. That's roughly the size of a tennis court, packed inside our lungs.
Incredible, isn't it? It's a masterpiece of biological engineering to maximize surface area within a limited volume.
How are they structured? Are they just individual balloons?
Not quite individual balloons. Think of it more like interconnected spaces. The respiratory bronchioles we just discussed divide into alveolar ducts. These are elongated airways whose walls aren't really continuous walls anymore, but rather consist almost entirely of the openings of adjacent alveoli. Rings of smooth muscle are found around these openings. These alveolar ducts then terminate in alveolar sacs, which are essentially spaces or clusters surrounded by multiple alveoli opening into them. Adjacent alveoli within these clusters are separated by incredibly thin walls called the interalveolar septum. This septum contains the dense network of blood capillaries where the gas exchange actually takes place.
So the walls between alveoli are packed with capillaries.
Exactly. The capillary network within the septa is the richest in the body, ensuring blood is constantly flowing very close to the air in the alveoli.
Okay, what are the key cells lining these tiny air sacs that are doing all this heavy lifting? The alveolar cells themselves.
Right. The alveolar surface is lined by a very specialized epithelium composed primarily of two distinct cell types. These are often called pneumocytes. First, you have type I alveolar cells, or type I pneumocytes. These are extremely thin, large, flattened squamous cells. Although they make up only about 40% of the total number of lining cells, they spread out so much that they cover about 95% of the alveolar surface area.
So they're thin and cover a lot of ground.
Precisely. Think of them like ultra-thin paving stones, forming an incredibly effective yet very thin barrier suitable for rapid gas diffusion. They are joined together by tight junctions to prevent fluid leakage into the airspace. Importantly, these type I cells are terminally differentiated. They are not capable of cell division. If they get damaged, they can't replace themselves.
Okay, so who replaces them and what's the other cell type?
That leads us to the type 2 alveolar cells, also called type 2 pneumocytes or sometimes septal cells. These are more numerous, accounting for about 60% of the lining cells. But because they are more cuboidal or rounded in shape, they only cover about 5% of the alveolar surface. They tend to be located in the corners or niches of the alveoli, bulging slightly into the airspace. They are secretory cells. Their most characteristic feature, especially visible with electron microscopy, is the presence of intracellular organelles called lamellar bodies. These are membrane-bound granules filled with parallel stacks or whorls of lipids and proteins.
Lamellar bodies. And these are all about surfactant, right? That substance that helps keep the lungs from collapsing.
Exactly right. Type 2 cells are the workhorses that synthesize and secrete pulmonary surfactant by exocytosis of the contents of these lamellar bodies into the alveolar space. Surfactant is a complex mixture, but its most critical component is a specific phospholipid called dipalmitoylphosphatidylcholine, or DPPC. It also contains other lipids and 4 unique surfactant proteins, SPA, SPB, SPC, SPD.
And its main job.
Surfactant's primary role is absolutely crucial. It decreases the surface tension at the air-liquid interface within the alveoli. Water molecules naturally want to pull together, creating high surface tension, which would cause the tiny alveoli to collapse, especially during exhalation. Surfactant inserts itself between the water molecules at the surface, reducing this tension, stabilizing the alveoli, preventing their collapse, and making it much easier to inflate the lungs with each breath. It reduces the work of breathing.
Which connects directly to problems in premature babies.
Precisely. This is the basis of neonatal respiratory distress syndrome, or NRDS. In premature infants, especially those born before about 35 weeks gestation, the type 2 cells haven't fully matured and haven't produced enough surfactant yet. Without sufficient surfactant, their alveoli collapse after each breath, leading to severe breathing difficulties, hypoxia, and exhaustion. The administration of exogenous surfactant, artificial or animal-derived, directly into the lungs is a common and often life-saving treatment for these vulnerable babies.
That makes so much sense now. What about those surfactant proteins?
The surfactant proteins, SPA, B, C, and D, also play vital roles. SPB and SDC are small hydrophobic proteins essential for the spreading instability of the phospholipid film at the air-liquid interface. Mutations in the gene for SPB are lethal without lung transplant. SPA and SPD are larger hydrophilic proteins belonging to the collectin family. They're involved in organizing the surfactant structure, but also play important roles in innate immunity within the alveolus, helping to recognize and clear pathogens.
So type 2 cells do more than just make surfactant.
Yes. Critically, type 2 cells also serve as the progenitor cells for the alveolar epithelium. Remember, you said type I cells can't divide.
Right.
If the alveolar lining is injured, say by infection or inhaled toxins, the type 2 cells can proliferate, divide, and then differentiate into both new type 2 cells and new type I cells to repopulate and repair the damaged surface. This regenerative capacity is remarkable and essential for lung health.
Are there any other cells lining the alveoli?
A few brush cells are also found, similar to those seen higher up in the airway. They are relatively rare, but likely function as chemoreceptors, perhaps monitoring air quality deep within the lungs.
Okay, so we have the air in the alveolus lined by these cells. Where exactly does the air meet the blood? What's that exchange point, the air-blood barrier, look like microscopically?
The crucial interface, the air-blood barrier, is located within that thin interalveolar septum separating adjacent alveoli. It's where the alveolar airspace comes into incredibly close proximity with the blood flowing in the pulmonary capillaries. It is astonishingly thin, optimized for rapid diffusion of gases. At its thinnest points, the barrier consists of only 1. The thin layer of surfactant coating the alveolar surface. 2. The extremely thin cytoplasm of the type I alveolar epithelial cell and its basal lamina. 3. The often fused basal lamina of the type I cell and the capillary endothelial cell. And 4. The thin cytoplasm of the capillary endothelial cell itself.
Fused basal laminae, so the supporting layers merge.
Yes. In many areas, the basal laminae of the epithelium and the endothelium fuse together, further reducing the diffusion distance. We often talk about a thin portion of the barrier where this fusion occurs and where most gas exchange happens. There's also a thick portion of the septum, usually where the cell nuclei are located or where there might be a bit more connective tissue, like collagen and elastic fibers or fibroblast cells. Tissue fluid can potentially accumulate in this thicker region, which could impede gas exchange if it becomes excessive, like in pulmonary edema.
An incredibly thin, specialized barrier. Amazing. And who cleans up this delicate environment, keeping everything pristine down there?
That critical job falls primarily to the alveolar macrophages, sometimes famously known as dust cells.
Dust cells, I like that.
It's descriptive. These are specialized phagocytic cells that function primarily within the alveolar airspace, crawling over the epithelial surface. They are the janitors of your deep lungs. They constantly scavenge inhaled particulate matter that manages to get past all the upper airway defenses, things like dust, pollen, bacteria, viruses, fungal spores, pollution particles.
Where do they come from?
They are derived from blood monocytes that migrate out of the capillaries into the lung tissue and then differentiate into macrophages. They're part of the body's mononuclear phagocyte system. Once loaded with debris, what happens to them? Well, many are cleared upwards via the mucociliary escalator, eventually being swallowed or expectorated. Others might migrate into the connective tissue of the septa. They also play a role in disease. They phagocytose red blood cells that might leak into the alveoli in conditions like heart failure, becoming hemosiderin-laden heart failure cells. They're also crucial in fighting infections like Mycobacterium tuberculosis. Some macrophages become long-term residents within the connective tissue of the interalveolar septa, called septal macrophages or interstitial macrophages. These can accumulate inhaled indigestible material, like carbon particles from air pollution or smoking, throughout life, contributing to the darkened appearance of lungs in urban dwellers or smokers.
So they're cleaning the air spaces and the tissue itself.
That's right. Oh, and one more structural feature worth mentioning are the alveolar pores, or pores of Kohn.
Pores between alveoli.
Yes, these are small openings, maybe 10-15 micrometers in diameter, found in the interalveolar septa, directly connecting the air spaces of adjacent alveoli. Their function seems to be to allow for collateral air circulation between neighboring alveoli. This can be particularly important if the normal bronchiole supplying a group of alveoli becomes blocked, say, by mucus in obstructive lung disease. Collateral ventilation through these pores might help keep those alveoli inflated and participating in gas exchange.
Another clever backup system. Okay, what are some other major clinical correlations related to the alveoli and these terminal airways that really underscore their importance and vulnerability?
Well, we've touched on RDS and emphysema already, but let's elaborate and add a couple more critical ones. Cystic fibrosis, or CF, is a devastating autosomal recessive genetic disorder. It's caused by mutations in the CFPR gene, which codes for a chloride channel protein that's crucial for ion and water transport across epithelial surfaces. In the respiratory system, the defective CFTR protein leads to decreased chloride secretion and increased sodium and water reabsorption across the bronchial epithelium. This results in the production of abnormally thick, viscous mucus.
Thick mucus, leading to blockage.
Exactly. This thick mucus obstructs glands and ducts, particularly in the airways. The mucociliary escalator we keep mentioning malfunctions because the cilia can't move the thick, sticky mucus effectively. This leads to mucus plugging, airway obstruction, trapped fluid, and provides a fertile breeding ground for bacteria, resulting in chronic, recurrent, and often severe respiratory infections and progressive lung damage. It primarily affects the airways, but highlights the importance of normal epithelial function.
A problem starting at the channel protein level.
Precisely. Then we have the broad category of chronic obstructive pulmonary disease, or COPD. This term usually encompasses chronic bronchitis, inflammation and excess mucus in bronchi, and emphysema. We should also mention that some forms of obstructive asthma fall under this umbrella too. Let's focus on emphysema. This is defined pathologically as a permanent enlargement of the air spaces distal to the terminal bronchiole, so involving respiratory bronchioles, alveolar ducts, and alveoli. Critically, this enlargement is accompanied by the destruction of the alveolar walls without obvious fibrosis initially. This leads to a significant loss of the elastic recoil of the lung and, crucially, a massive reduction in the available surface area for gas exchange.
So the tennis court shrinks.
Effectively, yes, making it incredibly hard to breathe, especially exhaling. Emphysema is most commonly caused by cigarette smoking, but other inhaled particulates can contribute. The underlying mechanism often involves an imbalance between proteases, enzymes that break down proteins like elastin, a key component of alveolar walls, and antiproteases in the lung. Smoking increases inflammatory cells that release proteases, and it also inactivates natural antiproteases like alpha-1 antitrypsin. In some individuals, a genetic deficiency of alpha-1 antitrypsin greatly predisposes them to early-onset emphysema, even without smoking.
Wow, destruction of the architecture itself.
Yes. And finally, let's mention pneumonia. This is a general term for inflammation of the lung parenchyma, meaning the alveoli and distal airways. It's most often caused by infections, either viral or bacterial, but can also be fungal or due to aspiration. In typical bacterial pneumonia, the infection triggers an intense inflammatory response. The alveoli fill up with protein-rich edema fluid, microorganisms, neutrophils, coming to fight the infection, and often red blood cells leaking from damaged capillaries. This consolidation process, where the airspace is filled with exudate, makes the affected lung tissue firm and airless. Early on, it might look red due to the red blood cells called red hepatization because the lung resembles liver tissue.
Hepatization, like liver.
Yes. Later, as red cells break down and macrophages come in to clear up the debris and dead neutrophils, the color might become grayish, gray hepatization. The lung remains firm. Eventually, if the infection is controlled, the inflammatory exudate is cleared, often by enzymatic digestion and macrophage activity, and the airspace is hopefully refilled with air during the resolution phase. But severe pneumonia can lead to scarring or complications.
So these conditions really highlight how crucial the normal structure and function of the alveoli are.
Absolutely. From genetic channel defects to wall destruction to inflammatory filling, disruptions here have major consequences.
Okay, finally, let's briefly look at the critical support systems that keep all these intricate structures functioning. The blood supply, the lymphatic drainage, and the nerves.
Right, the lungs actually have a fascinating dual blood supply. First, there's the pulmonary circulation. This is the large volume, low pressure system. Branches of the pulmonary artery carry deoxygenated blood from the right side of your heart to the lungs. They follow the branching airways and ultimately feed into that incredibly dense capillary network surrounding the alveoli for gas exchange. Then, the pulmonary capillaries collect the newly oxygenated blood, forming pulmonary venules and eventually the large pulmonary veins, which return the oxygenated blood to the left atrium of your heart. This system is located peripherally within the lung lobules, optimized for gas exchange away from the main air passages.
Okay, that's the main gas exchange circuit. What's the second supply?
The second is the bronchial circulation. This is part of your systemic circulation, originating from the aorta or intercostal arteries. These bronchial arteries carry oxygenated, high-pressure blood to supply the tissues of the lung other than the alveoli themselves. So they nourish the walls of the bronchi and bronchioles, the connective tissue septa, the nerves, and the outer layer of the lung, the visceral pleura. The finest branches of the bronchial circulation actually anastomose, or connect, with the pulmonary capillaries. Interestingly, most of the blood from the bronchial circulation ultimately returns to the heart via the pulmonary veins, mixing slightly deoxygenated bronchial venous blood with the highly oxygenated blood coming from the alveoli.
A dual supply for different needs? What about clearing fluid and immune cells, lymphatics?
Yes, the lungs also have a well-developed lymphatic drainage system, also somewhat dual. One set of lymphatic vessels originates deep within the lung parenchyma, around the terminal bronchioles, and follows the airways and pulmonary arteries back towards the hilum, the root of the lung. Lymph flows through lymph nodes located along the bronchi and in the hilum, important for immune responses. A second, separate set of lymphatic vessels drains the surface of the lung, traveling within the connective tissue of the visceral pleura, the membrane covering the lung. These drain towards the hilum as well. And as we mentioned earlier, there's significant bronchus-associated lymphatic tissue, BALT, found in the walls of the larger bronchi, acting as an important site for initiating immune responses to inhaled antigens.
And finally, the nerves. How is breathing controlled or modulated?
The lungs are innervated by components of both the sympathetic and parasympathetic divisions of the autonomic nervous system. These nerve fibers travel to the lungs primarily via the pulmonary plexuses located near the hilum. They mediate various reflexes that modify the dimensions of the air passages and blood vessels by controlling the contraction of smooth muscle in their walls. For example, parasympathetic stimulation tends to cause bronchoconstriction and increase glandular secretion, while sympathetic stimulation generally causes bronchodilation and inhibits secretion. There are also sensory nerve endings within the epithelium and connective tissue that detect stretch, irritants, and other stimuli, feeding back information to the central nervous system to help regulate breathing patterns and trigger protective reflexes like coughing.
So constant fine-tuning happening automatically.
All the time.
What an absolutely incredible journey through the respiratory system, from those coarse hairs, the vibrissae in your nose, all the way down to that tennis court-sized surface area of your alveoli. It's just a masterpiece of microscopic engineering. A tennis court-sized surface area inside our lungs. That's genuinely mind-boggling. I think I'm going to think about that every single time I take a breath now.
It truly is staggering when you think about the scale. And it really underscores how every single cell type, every layer, no matter how small or thin, plays an absolutely vital role in keeping us alive and functioning. And also how disruptions at this tiny microscopic scale, a faulty channel protein, inflammation, destruction of walls, can have such profound system-wide effects on our overall health and well-being. It's a system constantly working, often completely without us even realizing the immense complexity involved.
So what does this all mean for you, our listener? What's the takeaway?
Well, perhaps it's simply a renewed appreciation for that often unconscious, completely fundamental act of breathing. Maybe take a conscious breath right now and just think about the journey that air is taking. Or maybe it sparked a bit of curiosity about how medical science can intervene when things go wrong. Developing treatments like exogenous surfactant for newborns or inhalers for asthma, or understanding the mechanisms behind diseases like emphysema or CF. It also highlights the remarkable resilience of the lung, constantly facing environmental challenges, from dust and pollution to viruses and bacteria, and yet most of the time managing to keep us going.
We certainly hope this deep dive has given you a whole new perspective, a microscopic view on something as fundamental, as essential as taking a breath.
Remember, digging into the tiny details, understanding the histology, often illuminates the biggest truths about how our bodies function and really what it truly means to be alive.
Keep learning, keep exploring those details, and we'll see you next time on The Deep Dive.